Thanks again to everybody for joining us tonight. We're really excited to have both Seth Eisenberg and Marty Polovich here to speak tonight on a really important topic that everybody has a lot of interest in, USP 800. So the talk tonight is entitled Ready for USP 800, the next chapter in hazardous drug safety. A little bit more about our speakers tonight. Marty Polovich is joining us. She's been an oncology nurse for more than 30 years, clinical expertise in the care of receiving cancer, chemotherapy for cancer, patient safety related to the use of chemotherapy, and also adverse effects of occupational hazards of hazardous drugs in the healthcare setting. She's currently assistant professor at the Burdine F. Lewis School of Nursing and Health Professions at Georgia State University. Joining Marty will be Seth Eisenberg. He's been practicing in the field of oncology since 1983, a wide and vast interest in the field, as you can see from the slide here, and is currently practicing at the Seattle Cancer Care Alliance. He's published numerous articles on chemotherapy and biotherapy, written 3 book chapters, and presents nationally and internationally at nursing and pharmacy conferences. And he's an active leader within the ONS community. So again, really excited to have both Marty and Seth here tonight joining us for this talk. Just a couple housekeeping items to cover before we transition here. These are the disclosures for both Marty and Seth. Seth disclosed he's a member of Speakers Bureau for Becton Dickinson and also ISQ Medical, and consults with B. Braun Medfusion and Baxter. And Marty has disclosed she's a member of the Speakers Bureau for Becton Dickinson. The last really important thing before I kick it off is the CE credential to get credit for tonight's talk. So each of you have received this. You should receive it in front of you with your packet of slides. So there's 2 ways to obtain the CE credits. You can either go online to the website that's listed here, or you can fill this out tonight and leave it with us at the back door as you leave. I would encourage you to do this, so then it's taken care of and done with, and you don't have to worry about going online and afterwards to do it. So without further ado, I'm going to turn it over now to Seth to kick off the talk. Seth.
Thank you. I want to thank you all for being here tonight to listen to us speak to you about a topic near and dear to all of our hearts professionally. And so a couple things we're going to get started with here. These are the learning objectives. So at the conclusion of the session, you will be able to list the adverse outcomes of occupational hazard drug exposure, describe USP Chapter 800 standards that will impact oncology nursing practice, describe requirements for education and training of personnel who handle hazardous drugs, and discuss criteria to consider for selecting and implementing safety equipment for hazardous drug handling. So we'll start off with an overview of occupational hazards, but we do have an audience response question here that we're going to give you. And so in front of you are these little gadgets right there. Don't push them yet. I think most of you have probably seen these or used these in the past, and so we'll have these questions come up. There'll be one in the next slide. When you get to the slide, I will read it, but you don't have to wait for me to complete reading before you press your answer. There are no wrong answers here, and we're not keeping track of your names yet. So, okay. So, first question is, what best describes your clinical setting or place of employment? Inpatient, outpatient, private practice, or other? We don't have any Jeopardy music going here, but we will wait and see what kind of we get responses. And then we'll find out what the answers are. Okay, so here we have 40. Really? Who would have predicted that? I think it's rigged. So pretty much half and half with some on the other. So that's great. Maybe we'll talk later about the others to find out what other you are. So. All right, to start. So I always like to start off with a little bit of brief history of hazardous drugs. So those of you who've been around a long time know this, I'm sure, but we have newer nurses that are coming into the field of oncology, and I think it's always useful to give some perspective because they're not always getting this information. And I've highlighted for you in the red box here, which I can't read on my screen, but basically this is a 1979 article. It's the first thing published on hazardous drug safety, and I just want to kind of read this to you. Because I think it's really important. So it says that here, the agents also, but we know of no studies of the possible occupational hazards in handling of such drugs in oncological units. So there we were in '79, and I referred to this as the dark ages of hazardous drug safety, because all of us who've been around tell all the tall tale stories about shooting the adriamycin onto the cabinets and the dots, the red dots and things. Yeah, I see heads nodding. Yeah, I know who you are. So those are the dark days. But I put this in here because this is where we started, and it was a long time ago. '79 was a long time ago. So what we're going to do now, though, is ask you one more question before we moved on to more studies. So prior to today, have you heard of USP Chapter 800? There are only two options here, guys, so this should be simple. All right. So we got 66% said yes and 34% no. Okay, so 2/3 yes. That's great. All right, so we're going to talk a little bit about some background information, and this will be review for a lot of you. And I think before we even get to the details of this slide here, I wanted to preface by saying a lot of what we're going to talk about today is not new. There are some new things you'll be hearing. I can pretty much guarantee that. But there's a lot of things here that we've been saying at ONS and ASHP has said and NIOSH has been saying. What's different is, and I jokingly said this last night to Marty, is that there is a new sheriff in town, and that sheriff is USP. And the big difference between what we're talking about tonight with USP and what we've been talking about over the years with the other groups is that USP is going to be enforced. And that is the new sheriff. So why are we concerned? Well, exposure concerns, we know that these drugs cause DNA damage. That's the mechanism of action for a lot of the chemotherapeutic agents we use. There's an increased risk of cancer. We've learned that from our patient populations and from exposure by healthcare workers. Acute symptoms such as nausea, vomiting, rashes, nasal sores, hair loss. Oops, too late. Yeah, sorry. Reproductive effects, which are some of the biggest concerns we worry about, such as birth defects, low birth weight infants, infertility, miscarriages, and premature delivery, and learning disabilities of offspring of nurses who've been exposed. So we really have a long list of problems with exposure. So we're going to talk for a few minutes about some recent studies, because it's easy to say, well, we don't really have a problem anymore, that those studies from the dark days were from the 80s, and we do things so much better now, we don't have a problem. And so I'm going to present basically 5 studies very briefly to kind of show you what I think well-roundedly describes the state of our problem currently. So the oldest study that I'm going to start off with here is, well, it's not the oldest of the group, but the oldest one I'm starting with is from 2013. This was a wipe test study in 6 hospitals, and they were looking for cyclophosphamide exposure. They did 438 surface wipe tests in pharmacy and nursing areas, so 36% came back positive. Now that by itself is pretty startling, I think. Over a third were positive. But this is what I find even more interesting. Look at where they found the positivity. And I want each of you to look at some of these areas and tell me the last time you handled a pen or touched a bedside table or a computer mouse, were you wearing chemo gloves? We normally don't wear PPE when we're holding those items. But if you weren't, you were likely being exposed because they found traces of chemo on these items. The other question to ask is, how did the chemo get there? So we'll talk a little bit more about that later. So the same researchers did a different study a year later in 5 hospitals and 1 cancer center. And what they did was they did wipe testing of the hands of employees. So not looking at surfaces, but the hands, which is kind of a novel approach. And they had 110 different multidisciplinary staff. So they looked at physicians and nurses and dietitians, respiratory therapists, and a variety of groups, including the unit secretaries at the desks. And what they found that 20% of the staff tested positive. So that's pretty alarming. And that the staff that didn't give chemotherapy, so the non-nurses, non-physicians, non-pharmacists, had the highest levels of contamination. So what that says is, how did the people like the unit secretaries, which actually had the highest concentration, get this on their hands? Where did they find it? How did it get spread from the patient's room to the telephone or the computer terminal that they use? Keep that in mind. So the following years is another study that was a follow-up of the last study, and they looked at those same basic staff again, but they did urine sample collections on the participants. 55% of them were positive for cytoxin. Now, this shouldn't be surprising because we know that the first route of exposure is dermal exposure. First route is by getting it on your hands or other parts of your body. We'll talk about PPE later, but this is how it works here. Highest concentration was found on the unit clerks and other departments that did not prepare or administer chemo, and there was actually no correlation between people who said in a journal that they gave cytoxin that day and the people who said they didn't give cytoxin that day. So again, it goes back to what is in your environment. And we could probably spend an entire hour talking about wipe testing, but we're not going to have time for that tonight. So another study here. This was another study that was done in 3 U.S. cancer centers by Tom Connor. This is the study from 2010, so this is the oldest of all the studies I've got for you here. And they looked at exposed versus non-exposed staff on this, and they did wipe testing. 75% of the pharmacy samples were positive for at least one drug. 43% of the nursing samples were positive for at least one drug, and all of these centers supposedly used all of the current guidelines that were in place in 2010. Highest concentration of hazardous drug was not found in the pharmacy, but found on the lid of a disposal container in one of the dirty utility rooms. And when we get a little bit further into the presentation, we're going to kind of come back and refer back to this scenario when we look at why did it get there, but on the lid of that container. And 3 healthcare workers had positive urine tests. So we're going to hand this over to Marty right now. She's going to talk about some introductions to the chapter, and we will continue.
Thanks, Seth. I think it's really important that we always talk about the risks and the adverse effects of chemotherapy exposure and the fact that you are potentially exposed, because that convinces you of the interventions that you need to use in order to protect yourselves and your coworkers from exposure. So I'm going to give, if this is possible, in 10 minutes or less, an overview of USP Chapter 800. And those standards, I'll focus on those that are most likely to impact your care as an oncology nurse. So the first thing I want to explain is the difference between a guideline and a standard. So we are very used to talking about, well, that's in the guidelines, and what that means, it's a practice that's recommended. It's usually evidence-based, comes from a reliable source, and we usually refer to guidelines as what should be done. I want you to remember that word should. Now, an example of a guideline would be the ONS Chemotherapy and Biotherapy Guidelines and Recommendations for Practice. So that is considered what should be done in oncology nursing practice. On the other hand, a standard is something that's considered expectations for practice. The standards are always evidence-based, usually come from a reliable source. Sometimes they come from a regulatory agency. And these are considered what must be done in practice. And I want you to remember that word must, because standards that say must are things that, you know what, you have to do it. Doesn't matter if you like it or not, you have to do it. And a good example of standards are the Joint Commission standards. If you work in a facility that's Joint Commission accredited, the expectation is that you will meet all those standards. And guess what? There are implications if you don't, right? And sometimes those implications hit you where it hurts, like financially to an organization, because it can impact reimbursement for practice. So the USP, United States Pharmacopeal Convention, say that fast 3 times. In their compounding compendium, say that fast 3 times. Published General Chapter 800. That's why we're referring to this. It's a general chapter in that compendium. And it is titled Hazardous Drugs Handling in Healthcare Settings. It was published in February of 2016. I served as a consultant on that team that helped to develop the standards, but don't put the target on me. I'm just a messenger. And the implementation date is July 1st, 2018. So what's really interesting is USP has many standards, and this is the first time that they've given such a long time for the implementation of standards. Usually they are published and they have to be fully implemented within about 6 months. But they looked at the kinds of changes that had to be made in some organizations and gave a little over 2 years for organizations to come in compliance. Now, I don't want you to think that 2 years is a really long time if you have to make big changes in your organization, because the bigger they are, the longer it takes to get things done. But what's really interesting and important for you to recognize that the USP Chapter 800 applies to all healthcare personnel. It's not just pharmacists and not just nurses. It applies to anybody who is in a facility, any kind of a facility. It's not just a hospital where hazardous drugs are present. And there are no exceptions. Some USP standards in the past have had exceptions for low volume types of activities. But that's not the case with USP Chapter 800. If you're a doctor, a private practice, a hospital, a clinic, if you're not even involved in oncology, if there are hazardous drugs in your facility, then you have to be compliant with all the standards with USP 800. That's the challenge to some of us, because a lot of organizations don't even know that they have hazardous drugs on board. That's a very important message. So a brief overview of the standards. They state in the introduction to the chapter that the purpose is to promote patient safety, worker safety, and environmental protection. In the past, most of USP 800 standards have been for patient safety, like maintaining the sterility of drugs that need to be given IV and so on. But this is for patient safety and worker safety. 18 sections, okay? Now, not all of them are applicable to nursing care, but many of them will impact you depending on the kinds of activities you do in your facility. Facility and engineering controls are addressed, competent personnel, safe work practice, proper use of PPE, and the need for policies for hazardous drug waste and disposal. So I would like to tell you that I can't address all of these in this short period of time, but there is specific guidance written. First of all, the list of hazardous drugs. Now, to me, this is one of the most important standards. I know that sounds kind of silly, but you have to know what drugs are in your facility in order to label them, teach your staff about them, and manage ways that they're handled. So the list is like a really important one. Facility and receipt, where you receive drugs and store drugs, what containment requirements there are, the labeling requirement, that's extremely important. How do you communicate to personnel who handle the drugs? By a label of some sort. So there has to be, all the drugs have to be labeled. What are the types of exposure that you're susceptible to based on your type of work? The responsibilities of personnel. Environmental quality, which I'll talk a little bit about later, personal protective equipment, hazard communication, and the importance of training and medical surveillance for hazardous drug handlers. So, list of hazardous drugs. The requirement for the list is that it be facility specific. So, in other words, if you don't have a certain drug in your facility, then it doesn't need to be on your list. So you have to look at all the drugs that meet the criteria for being considered as hazardous, and every drug needs to be on that list. And any drug that's on the current NIOSH list, the most recent having been published in 2016, if it's in your place, it's on your list. The list needs to be reviewed at least every 12 months, which is more frequent than NIOSH reviews their list, because that's every 2 years. And you must include any newly approved drugs that meet the NIOSH criteria. So when new drugs are FDA approved, and how many were there in the last month? So you have to look at those and make sure that they're on your list if they meet the criteria for hazardous. So a list is essential because it identifies those drugs to which the precautions and other standards apply, everything from storage and so on. Hazard communication, this is an extremely important one. It needs to be a written plan for how the standards will be implemented. It has to include the labeling requirements, how that will be managed. Safety data sheets, we used to call them MSDSs. Did you know that changed in 2012 to SDS? Oh good, you're up on that. They need to be available to all personnel. Information and training has to be provided to individuals about the risk before their initial assignment to work that includes hazardous drug handling, and that needs to be repeated on a periodic basis annually to make sure that individuals are aware and are constantly reminded of the risk. And this is one standard that may be challenging for some of you to implement because your lawyers will get involved in this one. Personnel of reproductive capability must confirm in writing that they understand the risks of handling hazardous drugs. That's a direct quote from the standard on hazard communication. So you have to figure out some way to provide information and then to document that the information was received. Okay, do you compound hazardous drugs in your setting? Anybody who is mixing? Compound is the appropriate term, but if you mix chemotherapy as a part of your job? Okay. We have mostly no. We have a small number, about 13% of nurses. So there are many, many standards related to compounding of hazardous drugs. So the chapter addresses safe hazardous drug compounding. It requires the use of appropriate engineering controls that is, defined as biological safety cabinet or other types of equipment like compounding aseptic containment isolator. Say that 3 times fast. So it uses different language than you might be used to. Containment primary engineering control, CPEC. Containment secondary engineering control, that's CSEC, and the CSEC refers to the room in which the CPEC is placed. And then supplemental engineering controls, which at least CSTD, closed system transfer devices, easier to say. Requirements for all of those. Also, compounding occurs in a CPEC that's located in a CSEC. Your CPEC must be externally vented. That's nothing new. OSHA's been saying that since the 1980s, but it was a recommendation in the past. Now it's a requirement for external venting. This is one of the most challenging standards, I think, for people to implement, because if you rent your space, can you put a hole in, all that? It has to be physically separate from other preparation areas. You can't mix non-hazardous and hazardous drugs in the same setting. And you have to have appropriate air exchanges per hour in the room, and you have to have negative pressure to adjacent areas because that prevents the escape of hazardous drugs into the environment. And that's really an important one and one of the challenging ones. Then we have standards for hazardous drug administration. Now, we as the nurses who administer the drugs aren't used to having USP tell us what to do, right? They actually haven't addressed that kind of a problem anywhere in the past. It was usually about preparation. So what the standards say about preparation, the need for using protective medical devices, those that will provide protection for the worker, including needleless systems, even though there's not a lot of evidence that they will prevent you from being exposed to hazardous drugs, they're a safer alternative. Closed system transfer devices, or CSTDs, will be required. See that? You must use them for anti-neoplastic agents, not all hazardous drugs, but those that are anti-neoplastic agents, so that means chemo. You have to use protective techniques, and you have to develop them, such as spiking and priming in a safe manner and so on. Use chemotherapy-tested personal protective equipment, and avoid manipulating hazardous drugs whenever possible. That means you shouldn't be drawing up hazardous drugs outside of a controlled environment. You shouldn't be crushing tablets, opening capsules, and those kinds of things if you can absolutely stay away from that. So I listed them, the bottom line, the must standards. So USP has some musts and some shoulds. So these are the musts. You must maintain a hazardous drug list in your facility. You must label all hazardous drugs. You must designate an individual who's responsible for oversight of the safe handling program in your facility. So that most likely in a big facility will be someone like a pharmacist or a safety person, but if you're in a small practice, it may be a nurse. So someone is going to be responsible for all the record keeping and making sure that all the standards are being addressed. Designate areas for receipt of your drugs, for unpacking of your drugs, storage and compounding, using appropriate engineering controls, providing. Your facility has to provide PPE, and then you're supposed to use it. Follow all packaging, transport, and disposal standards, and must use CSTDs for administering anti-neoplastic drugs. So these are, there's more. Develop policy and procedures for all aspects of hazardous drug handling. Establish a hazard communication program. Provide job-specific training. So if you're a pharmacist, your training doesn't have to be the same as that of a nurse. If you're a housekeeper who cleans up in those areas, you have to have job-specific training. You need to know about decontaminating equipment and the environment. That's extremely important because we know that the environment is contaminated. And then you need to know how to prevent and manage hazardous drug spills. On the should list, this is the bottom line. Some of us are kind of upset that, some of these should have been must, but, there's compromise in everything. Still a step forward. Use of closed system transfer devices for drug compounding is a should. For drug administration, at least antineoplastics, it's a must. Environmental wipe sampling, which is a part of environmental quality control, is one of the should standards. We thought that would be a must, but should be baseline and about every 6 months. One of the challenges to doing that kind of environmental wipe sampling is that there are a few labs in the country that are available right now that do it, and they don't do it at a reasonable cost. And so it's not something that you can mandate at this time, but it's actually a good way to evaluate your organization at baseline. If you don't know you have a problem, but here's my thought on it. We know it's contaminated. You don't have to do a wipe sample. You can accept the fact that your environment is contaminated. And then this is the one that I'm most upset that is a should instead of a must, the medical surveillance for healthcare workers handling hazardous drugs. The recommendations are for baseline health assessment prior to starting to handle hazardous drugs, periodic assessment approximately on an annual basis, follow-up for acute exposure. If you have a spill and you have a spill on yourself, then you should have follow-up for that, and follow-up for any health changes that occur as a result of potentially handling hazardous drugs.
So we're going to move on and talk about some hazardous drug safety equipment. And I'm going to start off with PPE. And the interesting thing is about PPE is that for years we've been talking about PPE through ONS and other channels. But it's actually the least effective out of all the ways of preventing an exposure on the hierarchy of controls. But we're going to start off talking about that because it's the one thing that nurses identify the most. So some of this is not new, but some of it might be. So first of all, 2 pairs of ASTM 697805 tested gloves. So we know that approximately 25 to 30% of nurses generally have admitted to using double gloves, but not everybody uses 2 pairs of chemo-tested gloves. And they also have to have long cuffs because one has to go under the gown sleeve and one has to go over the gown sleeve. So there are a lot of chemo gloves out there. I talked to a bunch of nurses today who said, yeah, we got these gloves, but they're short-cuffed. And I said, those will not work. So wear time is 30 minutes, by the way, on that. So here's a question for you. Do you always wear a gown when administering hazardous drugs? You can be honest. We're not going to identify you. Okay, 64% yes, 36% no. Okay, that's actually good. It's going to have to get better, but that's good. All right. So another question, do you reuse a gown, meaning do you put it back on after removing it? Had a lot of conversations about this today with a lot of nurses. So answer is, so almost 2/3 are saying no. That's good. That's good. That's really good. And 1/3 of you are, so we'll be talking to you later. Okay, so let's talk more about PPE, so gowns. So currently there is no ASTM standard for gowns, although one is being developed. But the requirement is that number one, they are chemo-resistant. So how do you know they're chemo-resistant? Well, my recommendation is you ask the manufacturer to provide written documentation that they tested these gowns against which drugs. Not going to test every drug, of course, but anybody can market a product and say, oh yeah, this is Seth's chemo gown, and get you really cheap, get you a good deal of these. But you need to have some evidence that these are really working. So that's number one. They are single use, as we mentioned, and they are disposable. They must, of course, have a solid front with elastic or knit cuffs to keep a tight fit near the wrist area. And they, like I said, they need to be shown to resist permeability. So here's one of the big changes that I think is going to be a big eye-opener for most of us, is spill-specific respiratory protection. So USP 800 actually came out and said that you need to have appropriate respiratory protection during spill management for drugs that vaporize at room temperature. So unfortunately, there haven't been many studies on vaporization because it's extremely difficult to do, and there's really not a lot of money in doing these kinds of studies. But there are basically 8 drugs that we've listed here, and if you got my CJON article from last month, those drugs are listed in that article as well. So if these drugs spill, then you need to have the right kind of respiratory protection. And we're going to take a couple minutes to talk about respiratory protection because I find that nurses, we tend to get a little confused about this. So we're going to talk a little bit about vapors made easy and differentiating the difference between vapors and aerosols and the infamous N95 respirator. So some definitions. Vapors are small particles. You can think of perfume as a vapor. It's a liquid, and you put it on or you spill it, and what you smell are the vapors. Gasoline is another example. It is a liquid, but you can smell the vapors. Aerosols are much larger particles, and they're typically more visible, such as window cleaners. You spray your window cleaner on your mirror, you can see that. N95s and 100s are for aerosols and particles and will not work for vapors. Everybody clear on that? There'll be a test later, so I want to make sure we got this. Okay, so what do we need to use? So there are 2 options, basically. One is a canister, full-face canister respirator, or a PAPR, which is a powered purified air purifying respirator, with an organic vapor cartridge. The key here, number 1, is what kind of cartridge or canister is involved here. And the recommendations are organic vapor because if you think about this, it makes sense. These kinds of cartridges and canisters are designed for like nerve gas, okay, for sarin gas, for mustard gas. And where does chemo come from? If we trace the genetic lineage of chemo, it all starts with mustard gas, doesn't it? So there is a very good reason for choosing this type of a cartridge. The respirators, of course, require fit testing, and it has to be done annually. The PAPRs require information on how to use them safely and effectively, but they do not need to be fit tested. We recently purchased a whole bunch of these PAPRs for inpatient and where I work in the outpatient facility. And again, let me say this a second time, they're only for spills of those drugs. Okay? So you don't wear these for hanging the chemo. That was been, oh my God, the patient's gonna freak out. No. So, okay. Another question, of course. Do you currently use a CSTD for administration? All right, so let's see what our answer is. Survey says 70% yes and 30% no. I gotta tell you, that is really high, and that's great. I mean, because you have already conquered one of the first major challenges of implementing USP 800, is you have a CSTD. Now, I have to add to this that just because you have it doesn't necessarily mean that every nurse is using it. Because I have heard countless stories from people, I see heads nodding, countless stories from nurses who said, yeah, we don't like the product pharmacy uses, so we take it off and throw it away. You have to use it, not just have it in your facility. So, okay. So that's good. That's very good news. So closed system transfer devices, brief overview. They're designed to restrict hazardous drug, liquid or vapor from escaping into the environment, or another definition, prohibit the escape of HD into the environment. They must, there's Marty's must, there's a must be used for administration of chemotherapy when the dosage form allows. I mean, obviously you cannot do this for pills, but they put that in there. And they should be used for compounding. We'd already talked about that issue. Attach your CSTDs to the distal end of the tubing, so your primary or secondary, where drips can occur. We'll talk more about this in a second. Syringes used for IV push, sub-Q, or IM injections, IV bags if connecting or disconnecting the bag from the tubing. And all the manufacturers make different kinds of adapters for non-IV routes as well. So one quick story, I'm going to go off on a little tangent here, but a quick story regarding the distal end of the tubing and dripping from disconnecting from patients. So I was doing a lecture a couple of years back, and a nurse came up to me afterwards during the question and answer period, and she came up with her friend and said, you know, last week I splashed Cytoxan in my eye, and it still hurts. So we got into this big discussion. I said, how did you get Cytoxan in your eye? She said, well, you know, patients walk around with their IV poles, the tubing wraps around the pole. You know, it tends to do that. The pump tends to be doing that centrifugal force, it wraps around. So I disconnected the patient's tubing from their line, and I gave the tubing a little tug. And when it unwrapped on the pole, a droplet flew out and got me in the eye. So we had a lot of discussions about this. I mean, this is a really sad, unfortunately true story. And I said, well, you know, the problem is with IV tubings, it's like a garden hose. You disconnect the hose and wind it up, what happens? The water comes out the opening, and hydrostatic forces pushes it out the only opening you have. And tubing will always drip when you manipulate it. And our colleagues standing next to us said, well, yeah, I know, I've always seen drips going out of the rooms down the hallway to the chemo disposal bin in the dirty utility room. And now I refer you back to Tom Connor's study in 2010, where the highest concentration was on the lid of the container. If a CSTD had been in use by this nurse, she would have not gotten drips in her eye, and there'd be no trail of breadcrumbs down the hallway into her dirty utility room. And you ask yourself, how does chemo get spread around a department to end up on elevator buttons and on pens and on mice? That's one of the ways it gets transmitted. Okay, let's move to the next one here. So there are basically 7 manufacturers of CSTDs out there. You probably have visited their booths or maybe visiting their booths out on the exhibit floor. The first 5 out there with the asterisks by them are worth special note because they have what's called an FDA ONB code, which demonstrates that they actually have clinical evidence to support they do what they say they do. The 2 devices on the bottom do not have an ONB code yet, although I do know that at least one of the manufacturers is apparently pursuing an ONB code, but they do not have them. So there are 2 different designs or mechanical designs for closed system devices. And I bring this in here not to turn you all into engineers, but because you need to know a little bit about the 2 different types of designs. The first design at the top is basically what I call a lure-to-lure device. And basically those are the 2 brands and 2 models that are lure devices. And essentially they screw one lure connector into a lure device. They have the advantage of being very easy to use. They tend to be very small and compact and generally less expensive. The other style of CSTD is a membrane-to-membrane device. These devices work by squeezing 2 rubber or synthetic membranes together and then passing either a needle or a needleless device between the 2 membranes to pass the drug from point A to point B. And then when you're done, you disconnect by pulling it out, and it retracts the needle or needleless device and then separates out the membranes. One of the things about, and those are the devices listed there here, in general, the membrane devices tend to be more effective than the lure devices, but they also require the use of an adapter. And so I've got some pictures here. So this is actually a list of the devices lined up from largest to smallest on the side there. You'll notice the 2 smallest ones on the end, number 6 and number 7, are the 2 lure devices. And they get progressively larger as you go towards number 1 on the other side there. Not discussing how well these guys work, but I want you to get to see what they look like. And this is for demonstration purposes, and it's in your handout as well. This is what it would look like if you were giving an IV push of methotrexate or your adriamycin push. This is what it would look like on that. This is a sampling of the adapters that are required for connecting to tubing. So tubing uses a lure lock device. Lures are great. They've been around for a very long time. They were never really designed for hazardous drugs. So to use these membrane devices, each one of these comes with an adapter, and the adapters all look different. Some are bigger, some are smaller, but they all require the use of them. So the other thing that's interesting about CSTDs, all the manufacturers make various components to give you different ways of hanging your chemo. And so for a long time we said, pharmacy has to prime your bag with neutral solution, which is still correct. That hasn't changed. But there are other ways of doing it safely, and USP allows for that safety. So there are companies making these bag spikes, which connect directly to the bag. The pharmacy sends the bag looking just like this. If your tubing has a closed system device on the end of it, it connects directly to this, and you can do that very safely at the bedside. So that's the whole point of doing it that way. One of the other things that you are able to do is something called a dry spike, and here's 3 examples of dry spikes. And essentially what that allows is a couple of things. It allows for pharmacy to put these into the bag, inject the chemo through the CSTD device itself, send it out this way, but you can spike these at the bedside. And we've always said, oh my gosh, you cannot spike at the bedside. Well, the reason for that is because IV bags are very thin and IV tubing is very sharp, unnecessarily sharp. The good news about all of these dry spikes, no matter which manufacturer you look at, they're all extremely heavy, extra thick. So you can spike them at the bedside and do your priming. You have to prime that tubing with saline first, of course, but you can spike them there, or you can do a circle prime as well, which we don't have time for now, but I could talk to you about offline later on that. So a lot of things you can do here. If you do not have a device, for those of you who do not have a device, you probably want to do a trial, and you may want to do 1 or 2 different devices. So I would suggest, number 1, work alongside your pharmacy, because if you don't have a device, it means they probably don't have a device. And while you are required and they are not, likely, when you adopt a device, pharmacy will likely consider adopting a device as well. And that makes sense, because they're preparing the drugs, and so they should be using the same device as you are, but not necessarily. You can have hybrid systems. I know of several places that use 1 device for compounding and a different device for administration. But you want to have a meeting with at least pharmacy personnel there, and then you want to maybe develop even a hazardous drug work group. And members could include staff who are using the device, so pharmacists, technicians, and nurses, frontline nurses. You also want to get involved the clinical nurse specialist if you have one, management, because they're going to have to start writing the checks for these things. Risk management is always good to have involved because they need to know what's going on with safety of your staff. Nurse educators are crucial in this role for rolling this out and making sure everybody understands why we're using the devices and using the devices safely. And then maybe your purchasing department as well on these things. So you want to ensure that the devices you're looking at are compatible with your tubing and pumps. Not all devices work with all tubing and pumps. Most do, but there are a few that do not. So you want to make sure you've eliminated that issue before you take the time to bring in somebody to do a trial and realize this doesn't work with your pump or your tubing. The other thing is you really want to have good training. I've heard a lot of stories from people who use devices and the devices failed or they had lots of leaks and spills. And it almost always comes down to inadequate training of staff. And all of the device manufacturers have expert educators on their staff to help train your educators and train your staff to use these devices appropriately so that you don't have any failures with them. So you want to make sure you do that. And then you want to evaluate them for several criteria, such as ease of use, amount of training required, number of parts required, overall effectiveness, and overall cost. I'm going to switch back over to Marty. She's going to talk about competent personnel, education, and training.
So I've been an educator for a really long time, and we know the importance of education. I do want to stress that although education is necessary, it's not sufficient for changing behavior. But education is essential, and the standards in USP 800 require education, training, and competency validation for anyone who's responsible for hazardous drug handling. So they preface it by saying anybody who handles hazardous drugs needs to be competent to do so. So competency is more than just providing information. Information is essential, and that's covered in the Hazard Communication Standard. That means any employee needs to be aware of the risks of handling any hazardous substance in the workplace and the precautions that they need to use to minimize their exposure to these hazards. Education is the knowledge about the hazardous drugs themselves. Training is sort of the how-to thing. You can't just teach people, you have to show them the safe practices. And then the final piece to this is competency validation. So once you teach people how to do what they're supposed to do, you have to go back and see, did they really do it? And then you have to observe that practice, and you have to confirm that the practice is safe. And there's a standard requiring also documentation of that process. So some method of documentation that the training and competency validation came about in your setting. What the requirements for hazardous drug education include should be job specific, and you have to include all personnel who are potentially exposed because of the work that they do. So if you're responsible for compounding, it needs to be specific to safe methods for compounding hazardous drugs. If you're administering drugs, safe administration. If you or your other personnel in your facility are handling contaminated excreta, that needs to be part of the training. And you also have to include probably the housekeepers who are cleaning up after the hazardous drugs in the organization. Training has to be performed and documented, and it needs to be performed prior to assuming hazardous drug handling activities, so part of the orientation process. And if you ever have new policies, new equipment such as CSTDs that will mean changing the practice, you have to do training at that time. And if you have new hazardous drugs, the training or education or information must include at least these are the new drugs that we have on board. Competency, again, that documentation or demonstration of people using the precautions the way they were meant to be used, and documentation of the effectiveness of the initial training. So something at the end of orientation that says these individuals learned what they were supposed to do and they're actually doing it. And reassessment at least every 12 months. It's not just periodic. They do state in the standard that an annual basis of education. They're also pretty prescriptive about what the content of that education and training ought to be, how to identify the hazardous drugs, and what the risks of exposure to those hazardous drugs include. If you should have policies and procedures for hazardous drug handling, and the personnel need to be taught about what the policies say. It happens very often that I ask people, does your policy require this? And they're going, I don't know, I'm not sure about that. So that should be part of the training. What are the requirements? Proper use of safety equipment, because there's always room for user error, like with the CSTDs. Proper use of PPE, donning and doffing, how to put it on and take it off safely. What to do if you're exposed while handling drugs. If you have a spill on yourself, we're talking about, not just a spill that needs to be cleaned up, but if you are exposed while handling hazardous drugs, what's your policy and procedure for how you manage that? Then, of course, spill management and the proper disposal of hazardous drugs and the contaminated items that have touched hazardous drugs. So I just wanted to take a little bit of time to talk about identifying hazardous drugs and their risks, because the NIOSH list that was published in 2016 did have on it, you probably didn't know this, 217 hazardous drugs that meet at least one criteria, and there are 5 of them, for what makes a drug hazardous: carcinogen, teratogen, genotoxin, reproductive toxin, organ toxin, and a drug that looks like chemo, smells like chemo, acts like chemo is also a hazardous drug. What NIOSH did in the 2014 list was break the drugs into 3 separate tables. I didn't say groups, did I? Because that has implications for maybe we need to handle them differently, and that was not the intention of NIOSH. It never was. But they did list table 1 as all anti-neoplastic drugs, and 115 of those over 200 drugs are anti-neoplastic. The table 2 is non-anti-neoplastic hazardous drugs. 53 of the drugs on that list are non-anti-neoplastic drugs. That does not imply that some of the non-anti-neoplastic drugs are safer in any way than the anti-neoplastic drugs. And table 3, hazardous drugs with adverse reproductive effects. So in other words, those drugs only are hazardous to people who are actively trying to conceive whether you're a male or a female, pregnant or breastfeeding. Those drugs on table 3 are only harmful to people in those life situations. And so the rest of us don't need to use precautions, but if that applies to you, where you are in your life, then that's important for you to recognize. But as far as the anti-neoplastic and non-anti-neoplastic drugs, many of them also have adverse reproductive effects, okay? So you can't say, well, you're pregnant, okay, just stay away from table 3 drugs. Don't have to do that. Okay, I just wanted to take the time and talk about that because the reason they split it into 3 groups is that some facilities have a lot of non-anti-neoplastic drugs, but they don't give any chemo. So that doesn't mean that USP 800 doesn't apply to them. It means that it does. So for your non-oncology units, we don't give any chemo. Yeah, but you give a lot of non-anti-neoplastic drugs that should be handled as hazardous. All these standards, except the CSTD one, apply to those drugs as well. You should have standard operating procedures. Nurses don't talk about that. We talk about policies and procedures, but basically that's what it was. What handling activities, and what has to be done. Everything from the loading dock to the handling of hazardous drug waste. A friend of mine calls that the cradle-to-grave approach. So when it comes in the door until it goes out again, you have to have policies on how to manage those. Strategies to prevent exposure of healthcare workers. exposure by any of the routes of exposure. So that means you have to use biosafety cabinets. You have to use your compounding aseptic containment isolator and CSTDs. Those are the levels of engineering controls that protect workers. So you have to have policies on how to use the different equipment. Okay, does your facility's policy require double gloving for handling hazardous drugs? It's a policy and a practice thing, isn't it? So 68% yes, and 25% no, and 8% not sure. See, you have a policy, and a lot of people aren't familiar with the policy. That means you need to work on the education in your facility. How often do you double glove when administering hazardous drugs? All the time, none of the time, or whatever is in between? Okay, so, good, we have almost half of the people who do it all of the time. That's really good, I'm glad. But we do have a significant number of people who don't do it any of the time, and it may be those are the facilities where the policy doesn't require it. So I do want to talk a little bit about double gloving because I think it's an important one. But first, how do you select hazardous drug appropriate personal protective equipment? That they have to meet standards when there are standards as for gloves, and you need to have some evidence from the gown manufacturers that you have the appropriate PPE for the type of work that you're doing. And believe me, an isolation gown is not going to protect you from chemotherapy or hazardous drug exposure. Your policy needs to address when are you going to wear your personal protective equipment, and how often to change the personal protective equipment. And the guidelines that we've had for a long time recommend that about 30 minutes for gloves are enough. And there's some controversy about how often to change a gown. I'm not going to be able to go into that, but your policy can address that. And you should not be reusing disposable personal protective equipment. They're called disposable because when you take them out, you're supposed to throw them away. And when do you throw them away? When you take them off, okay? Now, I think this is a message that's really important for all of us to get and to take home to your colleagues. When do you wear double gloves, and why do you wear double gloves? If they're chemo gloves, they're going to protect me, right? Well, the main reason for wearing double gloves is not because we think the chemotherapy is going to leach through both levels of the gloves during the time that you're going to wear them, because it's usually a short time. But you take them off one at a time, and you take the outer gloves off. Do you remember learning this in isolation technique in nursing school? I know for some of us that was when Christ was a child, but you put your fingers under the glove, you turn it inside out carefully, not like on, who is that, Ben Casey? Slap that glove off and turn it. Don't do that because I am dating myself. Who's more recent than that? ER, okay. Turn it inside out carefully and dispose of it. Your hands are still protected by the inner gloves, right? So if you need to program that pump, clean glove, then you take your gown off and discard it. Your hands are still protected when you handled that contaminated gown, right? Then you take your inner gloves off and you discard them. So it's more of a work practice to protect your hands from contamination that occurs when you remove your personal protective equipment. You would do that for Ebola, wouldn't you? Okay. Sorry, I had to say that. So one of the NIOSH publication from 2016 has another table in the back of that particular document that goes over the PPE requirements. And so it's very prescriptive and easy to follow. For example, if you have an intact tablet of a hazardous drug and you're going to take it out of a unit dose package and give it to a patient, you can wear a single chemo glove. That's certainly appropriate. You do not need to wear a gown. You do not need to wear eye or respiratory protection, because what are the chances that unit dose package is pretty safe? However, if you have to manipulate it, what do I mean by manipulating? Crushing, opening capsules, mixing it in liquids, those kinds of things. Then you do want to double glove, you do want to wear a gown, you do want to wear potentially eye or face protection if somebody might vomit on you or spit on you or something. And if you have to crush it outside of a controlled device, then you do want to wear respiratory protection as well. So I recommend don't do that. Let the pharmacy do that, although you may have to argue with them about that. Oral liquid drugs, the precautions are listed here. IM, sub-Q, IV, the PPE is listed here for safety. So we don't need, NIOSH does not say you need to wear eye and face protection for all hazardous drug handling. I know many organizations do have a policy that say you put the face protection on no matter what you're doing with hazardous drugs. NIOSH doesn't say that. It says if there's a potential for splashing or if the patient may vomit or spit up. So your organization may certainly have a policy that's more stringent than that, but you're not required to do that. But that table back there lists all the possible activities for handling hazardous drugs and what PPE is useful. So you don't need to recreate the wheel for your policy, your government dollars at work. This table is yours to use and reproduce however you want. Now, I think we need to take a minute to talk about doffing. The OSHA people love that word doffing. We're talking about taking off the PPE after you've used it. So you want to remove your outer glove one at a time, turning it inside out. Then remove your face shield if you wore a face shield during that time. Then remove your gown, and it's important to pull it away from your body so that if there's any contamination on the front of your gown, you're not pulling it over your head and transferring that chemo residue to your hair or beard or whatever. Then remove the inner gloves, wash your hands with soap and water, and then if you were wearing a respirator, that's when it comes off, and then you wash your hands again. So that may be a little bit different than what you're used to doing, but that protects you for the longest time possible till all the hazardous drug residue has been discarded. So this, I think, is a really important message that you may not be aware of. There was a study published, I can't remember what year it was, a couple of years ago, by someone who was really interested in the Ebola kind of problem, but they put faux, like sputum on the gowns and gloves, and they had individuals doff their PPE, take their gowns and gloves off. And this was a really surprising result to me. 53% of the time, the gloves were contaminated. And 38% of the time, the gowns were contaminated and they were transferred to the individual. The good thing was they weren't using Ebola. They were using, fluorescein dye and some little pasty kind of stuff. But that tells us that we're not careful when we're removing our PPE. The purpose is to protect us. And then if we transfer that contamination to our body, then there's the opportunity for exposure. So that's an important thing to consider, the safety of removing the personal protective equipment. And there's a little demonstration here of how to do that. Removing contaminated gloves and gowns frequently results in the transfer of that contamination from the PPE to your skin or to your clothing, which means then you're taking it home to your family, okay? So I don't want you to do that. So see how the nurse is taking the gown away from her so that she won't transfer that contamination. If you should have a policy about your response to acute exposure. If you have an exposure, a spill or a drip or whatever, then you should have an institutional protocol. USP is not prescriptive about what that protocol says. However, it does refer to the SDS for what the first aid would be for exposure, that you should report to employee health or the emergency department, whatever your protocol says, and that you should report those exposures so that you have a way of tracking them. So what's recommended here is from ONS, how to handle an acute exposure for skin, eye contact, inhalation, or ingestion. So USP is not that prescriptive, but ONS has recommendations for that. Spill management, they're also not very prescriptive about how to manage a spill, except that your organization should have a policy in place on how to clean up a spill, so that you refer to that. The standard does say that somebody who's qualified and trained to clean up a spill needs to be available anytime hazardous drugs are handled. So that it means if you give chemo 24 hours a day, somebody every day, all day, and all night needs to know how to clean up a spill and be prepared to do that. You're also required to have spill kits of some sort. That doesn't mean you have to purchase them, but it means you do need to have the equipment available to personnel. And they also state, this is the first time I've ever seen this in writing, clean up that spill right away. There's some drugs that if you let it sit, it's harder to clean up. And then so they want you to clean it up as soon as possible after the spill occurs. And there's also a requirement to documenting and reporting all spills. So your policy needs to say who is responsible for cleaning up spills, what PPE to wear when they're cleaning up spills. There's supposed to be some judgment about how big the spill is so that you know if your spill kit can clean up the whole spill. And you're supposed to also specify what products to use to clean up after the spill. And it's not specific. The standard is not specific, but your policy should be. You're also required to have a sign to post to say, don't come here, there's a spill. And then how to dispose of all the spill materials. Disposal of hazardous drug waste, including trace contaminated materials, must comply. This is how they get around being very prescriptive. You have to comply with all state and local and federal laws. But of course, states vary a lot in what they require, what is considered trace waste. I've been in states talking about, oh, you need to put that in a chemo bucket. Oh, not here. We put that in the regular trash. So you need to be familiar with what your laws are and what's considered trace waste. Many places consider a gown that's not visibly contaminated trace, not even trace waste. That they say it's okay to put it in the regular trash. You need to work those details out in your organization based on what the disposal requirements are in your state. But everybody who's responsible for taking down chemo or for handling chemo waste needs to be trained on how to do that and what they're supposed to wear when they're doing that. But keep in mind that handling of waste does result in environmental contamination. And one of the goals of USP 800 is to protect the environment from contamination with hazardous drugs. So this is an important message. Always consider PPE contaminated when it's worn to handle hazardous drugs. Oh, I didn't get any chemo on my gown so I can wear it again. The study that I talked about, 38% of the time the gown is contaminated, and whether it's visible or not, you should consider it contaminated and not reuse. And then you need to have designated containers for throwing all this stuff away. So I just wanted to refer you to some resources. If you're feeling a little overwhelmed because maybe you're not meeting all the standards in your facility right now, there are lots of resources that are available that will help you be compliant. The first is listed, the NIOSH, it's 2016 NIOSH document that has the table of hazardous drugs to help you with your list, the tables in the back, and the tables for PPE. The OSHA has new guidance that tells you that will help you with that. The hazmedsafety.com is a website that is specific for information related to hazardous to USP 800, and it's a very good resource for you. Safe handling of hazardous drugs, the ONS book. I'd like to say it'll be out in 2017, but I don't know what month in 2017, but it's going to give you guidance on meeting USP 800. And then ONS also has model policies. You can buy policies one at a time or the whole manual that will help you with that. And then we have some resources for education, training, and competency. Many websites right here, like the NIOSH website that lists, it's a big bibliography, but also what recommended PPE and safety equipment. There's training information on the OSHA website, and ONS in combination with pharmacy, ASCO, and APON, right, got together and we developed a personal protective equipment guide that you can download, and it's like a poster you can post so everybody knows what equipment they're supposed to use. A reminder here of how to get the continuing education credit that we talked about earlier. Remember again that you have to complete the evaluation, no ticky, no washi, no evaluation, no CE credit. And we want to thank the sponsor who gave commercial support for doing this activity. That was B. Braun.